Hey, everybody, and welcome to the Research Roundtable, moderated by Dr. Karen Herbst, Lympha Press Chief Medical Officer. We have special guests today, Eric Ansart, who is the president of Lympha Press, and that says a lot about the relationship that he has with our other special expert tonight, Dr. Mark Melin. So glad to have you. Your affiliation with the Mayo Clinic, your history, you are Mr. Glycocalyx. You have a storied career. You know, I tried to write this long bio, and he's like, no, just tell everybody I'm a dad. I've been married 37 years, and I went to Honduras with Dr. Karen Herbst. So that's an interesting comment. And you folks are in for a treat because the pre-show was scintillating. I will just do some lay of the land. If you have logged on, please let us know where you're logging on from. We're so glad that you're here. If you have questions, put them in the Q&A. Dr. Herbst will weave them in as she finds space to do so. And with all of that said, I'm Brenda Viola for Lympha Press. I'm about to disappear so we can buckle our seatbelts and have a great conversation. Take it away, Dr. Herbst.
Thank you so much. You know, first of all, it's such a treat to have Eric Ansart on. You're just you have such great insight into all things vascular lymphedema and the Lympha Press. So thank you so much for joining us tonight. And Mark,
wonderful.
We've known each other for years. So great to have you on.
Can I just call out Eric on something?
Absolutely.
I mean, because right,
I'm ready for it. That's why I'm here.
We've had a ton of help on the arterial pump with Eric. We've had a ton of help, and the other thing is, you know, leadership with National Lymphatic Network. So Eric's been a huge ambassador for the industry, and it's just been such a pleasure to be with Eric over these years.
Absolutely.
And Eric,
thank you.
So, yep.
Yeah, thank you both. I'm so excited to be here this evening. I don't have a chance to jump in. I'm actually in PA. I'm up here traveling and had the opportunity to be here tonight. And Mark, you talk about advocacy for lymphedema and artists and arterial conditions. So this is not, I don't know that we've actually ever shared this. Mark spearheaded a whole initiative to go to CMS to try to get the ART-Assist and arterial devices covered, had a huge contingent of other vascular surgeons that came to that meeting. And really, I think in a lot of ways, we owe vascular coverage right now for the arterial device to those initial efforts. I mean, it was a monumental undertaking and really did it behind the scenes. Nobody knew about it. And Mark rallied this whole team together, and it's just been great. Really.
Yeah, we had a good time, and it was we had a great time being ambassadors. Right? I mean, it all just worked out well. We had a lot of people that came and helped in that effort, so that worked out well.
Yeah, we really did. Really did.
Okay, so just so our audience can get to know you a little bit, Mark, can you kind of give us an idea of like what is a usual day for you in clinic as a physician?
So I'm in Rochester, Minnesota. I'm in the Gonda Vascular Center. I'm the medical director for the wound clinic, and my days are spent doing wound care, so direct patient contact, and then we're working on some research efforts in wound care, and we're just a lot of collaborations. So the wound clinic has gone from a lower extremity only to head to toe, front to back.
Wow.
And as we've gone to comprehensive wound care, we've become great collaborators with ENT on big head wounds. So people that have had basal cell, squamous cell malignancies, and the radiation of sequela, and then working with our orthopedic colleagues in chronic issues, working with our dermatologists. And so it's been a really great multidisciplinary collaborative effort. And what I've learned is that no matter where the wound is, except for head and neck, because the drainage, gravity effect on the head and neck is different than below the clavicles or the collarbones. And really, every wound below the clavicles has some form of dermal lymphatic dysfunction that complicates wound healing. So any wound I see, my first thought is, how do I improve the lymphatic function in that peri-wound margin? And how do I improve the lymphatic function in that limb? And how do we maximize that? Because that ends up being improving immune function, soft tissue recovery, and ultimately, as we're going to talk about, improves microvascular arterial perfusion to the wound bed. So you'll hear me use a lot of farming analogies and flooded farm fields and drain tile. So we talk all the time about how the lymphatics in the skin are like drain tile. And when drain tile works effectively, it drains all the flooding. But most of our patients are like a flooded farm field with 2 feet of standing water with cow manure, and there's no oxygen or nutrients getting to the soil. And no farmer would ever put corn seed and phosphorus and manganese into and nitrogen into a standing field like that. And yet, if you look throughout the country in wound care, people are putting on all these really expensive products into these types of wounds where they think they've done good wound care prep, et cetera, debridement. But until you take care of that dermal lymphatic function, I truly think it's hard to get them to heal. And once you do that, the vast majority of wounds actually heal on their own, and they don't need a complex product to get them healed.
Well, you mentioned that there's lymphatic dysfunction in every wound, dermal lymphatic dysfunction. Is there peripheral arterial dysfunction in every wound?
Well, it depends on what scale you're talking about. So even in people that we see with palpable pedal pulses, if you go all the way down to the root system, because oxygen nutrient delivery is not till the 8 micron level, so that's 1/3 the size of our hair. And so if you've got a lot of peri-wound edema, which we may see as a pibbly at the wound edges, we may see as sponginess, and then you see all that inflammation, which just leads to things like cellulitis. But if you've got that around that wound, you're not getting 8 micron arterial perfusion. That's oxygen delivery. So I would maintain that almost every single wound we see has, or chronic wounds, so greater than 30 days, has some degree of microarterial perfusion problems, even if you can feel a pulse. And it's one of the things we see, especially in diabetic neuropathic ulcers. We can feel pulses. We can document that their ABIs are okay, or they may be calcified and their toe perfusion pressures are okay, and they're still not healing. Even the ones that are on the dorsum of the foot, and it may not be a pressure-related issue on the plantar surface of the foot. And I think this is really just a great untapped area. Certainly, there's not a lot of education in this area, and I think we're just kind of on the forefront of these types of discussions. I mean, Caroline Fife, right, is another big advocate for this. Brian Tuckey talks about this. So there are people starting to get this on the radar screen, but we need visualization. How do you show dermal lymphatic dysfunction? Of course, near-infrared fluorescence imaging, which Eva Sevick and John Rasmussen and Melissa Aldridge have championed, as a great way to see stasis even in peri-wound areas besides generalized lymphedema at the lower extremity.
So can it's one of the things we don't talk about is PAD a lot. So can you define it for us? What is it exactly? Because you were talking about, real microvascular, but what is the whole range of PAD?
So macrovascular would be lack of a palpable pulse. So make sure and check femoral pulse, popliteal pulses, which can be hard to feel, dorsalis pedis, and posterior tibial. And so if you can't feel pulses, which oftentimes in people with edema, you're not going to be able to feel pulses, standard of care is to get an ankle-brachial index. It's a non-invasive study. It's relatively inexpensive. Don't jump straight to a CT angiogram that has radiation and dye exposure. And so by putting a cuff on the calf, cuff on the toes, and you do right and left, and then you measure both blood pressures in the arm. You take the highest blood pressure, because some of these patients will have a subclavian artery stenosis as well. And it's taking the arm and the brachial and the foot pressure, and that gives you an index. So typical would be 1.2. Once you get below 0.8 or 0.7, you're going to have that's defined as peripheral arterial disease. The other thing that's really important to look at is the angiosome perfusion of the foot. And we've had multiple cases where you can feel a really good pulse in the foot. Patient's got a heel ulceration, and it's because a dorsalis pedis will not perfuse a heel well. You need the posterior tibial or inline perfusion. So those patients, it's important to look at getting further imaging. So it might be a CT angiogram, it might be a regular angiogram, because they could have a stenosis in their tibial peroneal trunk or in the posterior tibial artery, and they're not going to heal a heel ulceration unless you reestablish flow. So palpable pedal pulse does not mean you'll heal a heel ulceration. So even thinking about the foot in that type of distribution is important. And the analogy I use is, if you've been up in a plane and you've seen those 3 circular fields, right?
Mhm.
Where there's water going to them. And 2 fields can be dry and 1 field can look totally green. Well, they're all fed by the same watering system, but the watering system shut off to these other 2. And even though the 1 green field is immediately next to the 2 dry fields, it doesn't get enough water to grow plants in those 2 dry fields. So that's the angiosome concept. There's also lymphosome concepts, which of course the alert system down in Australia has put together, Dr. Sawami and his group. So we can even, you could start to match lymphosomes that aren't functioning. It's harder to measure that, in
It
a
is.
validated qualitative way. You can do it a little bit clinically, but the way to think about it is there's 4 main routes out of the leg. And Karen, you're an expert in this stuff, so correct me if I'm saying anything wrong. But if you look at the ventral medial bundle along the saphenous nerve, the great saphenous nerve, that's about 70 to 80% of the lymphatic flow out of the leg. And then you've got some going up the small saphenous vein on the back. And then you've got 2 other routes that feed the dermal out. So you can have a really swollen leg. And it's interesting when you look at MRI imaging or CT imaging, the skin's really swollen and the muscle and stuff may be just fine. And this is why the superficial lymphatic reconstructions really do a great job at decompressing the lower extremity. And that's why certified lymphedema therapists are so valuable, because they can move that fluid well to help us in terms of wound healing. So I'm going to come back to peripheral arterial disease. So think of angiosomes. I would advocate that anybody with a lower foot ulcer, even if you think you can feel the pulse, get a ankle-brachial index and get a foot x-ray. Because like today was a great example. I had a gal, she had forgotten about the foot surgery and she had a big piece of hardware in her foot. So you always have to think, is that infected? And then what's the ABI, so we can make sure we're getting this healed. So I think those 2 pieces at minimum, ABIs, and then x-rays of the imaging of the feet if you're dealing with a foot ulcer.
Well, it's interesting. Everything is always more complicated than we think. We talk about arteries, nerves, lymphatics, veins, but when you talk about angiosomes and lymphangiosomes, that's getting more complex. So you've mentioned a few patients. Do you have any cases that you could kind of show us, like what you see and then what you do, and give us a better idea of what's going on with wounds?
Yeah, and I just saw Kathy came up and said, what's ABI? So ABI again stands for ankle brachial. So the brachial pressure in the arm index. And so again, you're taking the ankle pressure divided by the brachial. That'll give you an index. 1.2 and above is probably partially calcified, like we see in our diabetic patients. And then 0.8 to 1.2 is within that normal range. And then if you go below 0.8, 0.7, that's where you start to consider that they may have arterial disease, and you're going to look for further imaging and further evaluation. Yeah, I've got a couple cases if we could bring those up. So here's a gentleman, 80-ish-year-old male, not a diabetic, prior extensive tobacco use. And he, interestingly enough, has true primary lymphedema tarda. So late onset lymphedema. He's not had any previous deep venous thromboses. And if you look at the wound, so his both feet over to the side, and then the wound next to that is the lateral or outside aspect of his left foot. And this ulcer, if you just look at it, looks relatively benign. My favorite tool in clinic is just a sharp metal curette. And I like it better than a Q-tip, because Q-tips, when you try to push them into wounds, they can meet certain resistance. You slide in that sharp curette and it just will automatically go wherever there's undermining. So we have found more osteomyelitis, more deep space abscesses, more areas of undermining using that tool. So if you can get a tool like that, it's incredibly helpful. And so you see in the third image, that pink, or that where I drew purple on his skin, that's how far that curette slid in. Right. Wow. So that's going up along the lateral aspect of his foot. And then he's got, and it was tapping on bone. So clinically, even if the x-ray says no osteomyelitis, clinically, I'm worried about osteomyelitis, and I'm going to go to the next stage after the x-ray of getting an MRI. And my advice is, don't skip the foot x-ray. Get the foot x-ray, because when the MRI reader is looking at the MRI, they can bring up the foot X-ray and it helps them to correlate. And so he came to us just because below knee amputation was recommended, and he wanted to see, is there anything else you can do? The challenge with him is with his neuropathy, you can see the kind of inversion of his foot. So he's got some biomechanical disadvantages on his foot. He's almost walking on the outside of that. And think about the shear. So as those edematous soft tissues are rubbing, it's like if you put your hands together and you rub your hands for 100 times, you're going to get a blister because your soft tissues shifting on each other, especially over the hard structures. So that's why you end up with that undermining, is because we have significant edema. We've got altered biomechanics of the foot. And then he's got let's go to the next slide here. Significant undermining, pedal pulse is not palpable. So again, we're going to get ankle-brachial diseases and do the workup. And then we started a pure hypochlorous acid irrigation twice a day, just to try to get down the biofilm. Because if you look in there, it's kind of like, now this is going to be gross. It's kind of like inside a sinus, right? That grimy, snot layered inside that wound. Well, that's all biofilm, and biofilm is going to hold on to a lot of bacteria. So irrigating that with hypochlorous acid twice a day. And then we can either moisten new gauze as a wick to put in there, or there's also now hypochlorous acid gel. Is this CME, Karen?
No, you can say whatever you like.
So there's a company, I'm sure you've all heard of them, called Ergo, and we use a lot of Vosh. There's also another good company that's in Missouri called Pure and Clean, and they have a hydrogel spray. Vosh just came out with a Vosh gel. And so when I look at wounds like this now, it's like filling it like caulking. And if we can get something in there that can do continual integrated debridement and debride 24 hours a day, so you're filling the whole hole, so you have complete contact with the surface. When you put in new gauze, you're really only touching a fraction of the surface. You're not treating all the biofilm. So the caulking filling method seems to be working pretty well for getting these areas at least started on the biofilm mitigation pathway as we're finishing the workup of getting the MRI, getting the ABIs, et cetera.
Mark, can I ask you a question?
Yeah.
About the biofilm? That's kind of a, buzzy word in a number of fields, and including infectious disease. And I know you kind of explained it as a snotty mess, but can you explain what a biofilm is a little bit more?
So biofilm is where bacteria has had a chance to proliferate, and then it creates its own kind of like gel layer that protects it and seals it off from the other tissues so it can kind of thrive. So it's not getting oxygen, it's not getting blood flow. And really good point that you're bringing up, Karen, because if we think about antibiotics and antibiotic stewardship, if we're giving this patient oral or IV antibiotics, how do we know about the concentration of that antibiotics getting actually to a very edematous field? I think it's probably low. So the better you do lymphatic treatment or dermal lymphatic stimulation, and here you can see these long lines. So we're using either Spandage or we're using edema wear to do circumferential 24/7, 24 hours a day, 7 days a week, MLD on this. And then certainly there's many patients that this were a venous leg ulcer, get them into a good lymphedema pump, because anything we can do for edema reduction is going to be of significant benefit. So, but I think from an antibiotic stewardship standpoint, treating that biofilm, getting the inflammation down, if you get the inflammation down, that's going to help get the swelling down. If you get the swelling down, both from that approach as well as from treating the dermal lymphatics, now we're going to get, I think, much better antibiotic penetration of that area to actually be effective. So I think good lymphedema control and good biofilm control also augments your antibiotic stewardship.
And Mark,
they're asking
a
for
question. Karen, did you mind if I ask a question? I'm just
Yeah,
curious with
please.
the previous picture you had, and you may be getting to this, so if I'm stealing your thunder, just stop me in this, but there's that pattern. I think you briefly alluded to when you mentioned edema wear, but what are you using there, and what's the intention that you're creating with that pattern? Is that for?
So we know dermal lymphatics will go up and down the leg. They don't go across. So this is that furrows in the farm field approach, where when you're prepping the farm fields, you want the lines to go. When people do MLD, they're kind of visualizing, we have to go this way. We're not, and so this is only 8 millimeters of compression, right? Just like your advanced pump is going to be stimulatory compression or stimulating the dermal lymphatics. And then over top of the edema wear or the bandage, if we're using that, we'll put short stretch wrapper of Velcro to get a little bit of extra static squeeze. So instead of just squeezing the toothpaste, we're trying to get the siphoning effect. So that's called the Guyton principle. When you create lymphangion contractility, it's like a siphon. So you're actually sucking the fluid up instead of squeezing or pushing it up. It's much more effective. In fact, I remember Dr. Olszewski, God rest his soul, right? Passed away in Poland, just a great scientist. But I still remember reading one of his papers where his thought was we should squeeze super hard. And then he did these wonderful biopsies and showed they were pushing fluid up through extraluminal channels. Well, you can move a lot of fluid that way, but my concern is why not use the innate endothelial tissue that's within lymphatics, get lymphangion contractility, get decompress the leg. And I think the decompression edema reduction is much more effective by using what is inherent to the tissues instead of creating extra channels. And the other thing, back to the glycocalyx, you want the glycocalyx functioning within lymphatics, within arteries, within veins, because that's what helps all those vessels work better. Plus, it decreases microvascular permeability. So you're really getting the whole thing by doing this stimulation and to get it out of the leg. So does that answer the question, Eric?
Yeah, absolutely. Thank you.
And then the other thing is there now is a new a lot of people are using nighttime garments. There's a nighttime garment that just has come into the United States from I think it's Haddam, called the Comfy Wave.
Yeah.
But the Comfy Wave, and that also kind of leaves those same type of lines in the legs. Susie Amon's been, Susie's done a lot of work in this dermal lymphatic stimulation area, and she did some great benchtop modeling with this type of stuff. But we are always looking, and it also helps me tell patient compliance when they come in and we take the pictures. If they're wearing I can instantly see the imprints on the skin and know that they're being compliant with utilizing the devices that we're talking about.
Is this wound that you're treating here lymphatic in nature, or is this an arterial wound that has
This is more of a neuropathic ulceration from diabetes and just not being able to feel it. When you lose your nerve innervation of the foot, it changes the structure because the tendons and the muscles shift. And when those shift, it changes the architecture of the foot. So you can get a Charcot foot or other types of changes. And then next thing you know, you've got a wound from abnormal pressure and abnormal walking. But the lymphedema certainly complicates the situation. That flooding of the tissues complicates this wound healing. And I think if we put this case up in front of a bunch of people in wound clinics, because we lack in the United States medical education at the medical school, the residency level, at most wound conferences, they're not talking about the lymphatic component. I think a lot of people aren't even going to recognize and treat the lymphatic component. We see this is one of the talks I gave down at Desert Foot with Dr. Frickberg this fall, was just recognizing the swollen component of diabetic foot ulcers. I think we could change amputation rates in the United States just by getting edema resolution in diabetic foots. And the data out there for doing good compression in people with diabetes and edema is really good. And low-hanging fruit, look at their medication list. If they're on amlodipine, make sure and get them off the amlodipine or other medications that cause microvascular hyperpermeability, because they're just compounding the problem. So if we have somebody that comes into the clinic and they're on Norvasc or amlodipine, we'll message their PCP so they can get off that medication. We've had people lose 5, 10, 15, 20 pounds in 4 to 6 weeks just by getting off that medication. and their edema comes down dramatically in their legs. And it's going to come down their legs first, of course, because it's gravity dependent, right? That's where the fluid wants to sit. And then you look at the chair sleepers, people that don't elevate their legs, et cetera. So other medications that can impact lower extremity edema, we've seen it with Lyrica, we've seen it with really high dose Neurontin, high dose calcium channel blockers, we've seen it with. So, and of course, in renal failure, congestive heart failure, liver, and hepatic dysfunction.
We've seen it with
Wow.
aromatase inhibitors as well, for
Yeah.
breast cancer.
Yes, for sure. I mean, to get that capillary leak syndrome type issue where they're just leaking all over the place. I think Karen, because I think it's shedding the glycocalyx.
Yeah.
You're shedding your Gore-Tex layer of your vasculature with a lot of those medications. And it's great for treating the malignancy. You end up with these secondary effects.
I didn't really think about that. I mean, I know calcium channel blockers, you've got fluid following electrolytes, but I'll look into that. Do you think
next.
do you think like a GLP-1 receptor agonist or an amphetamine might help this?
So the GLP-1s, certainly if you've got a weight component, poorly controlled diabetes, I'm sending a lot of people now to bariatric endocrine to get put on GLP-1 agonists.
Mm-hmm.
So I think more study has to be done in that area to prove that it really benefits wounds, and then why does it? There's now good data showing that it helps increase HDL and decrease LDL, so it may be changing your cholesterol profile. That may be why we see less heart attacks, less strokes in people on GLP-1 agonists. But in the United States, as I understand, again, correct me if I'm wrong, Karen, but I think the leading cause of lower extremity lymphedema is central obesity.
Yeah.
And so if that's the leading cause right now, anything we can do to get BMI down is going to help more effectively manage lower extremity edema.
We microdose it. So even in small people who have a lot of inflammation, it can be helpful. So I wouldn't hesitate to use very small doses in somebody who is small but had this amount of swelling.
Yeah, and that microdosing concept, is that a relatively new concept?
Yeah, I mean the only one that you can microdose if you get any a compound medication, but the FDA is really cracking down on that. So the only company that provides a vial right now is Eli Lilly tirzepatide, and so we pretty much so use them exclusively. And obviously they know we're microdosing, otherwise they wouldn't have a vial, but they just don't have the studies to support it. So we need a lot more studies on microdosing. I hope they do run one someday.
Yeah, and I think it makes sense since GLP-1s are natural to your body.
Yes.
It's just what, and then do you do both
GLP
dosing?
is.
Or GLP, yeah, and then what are the right? Do you go for a month, stop for a month, you pulse it? I think there's so much.
There's so
studies that
much
could be done.
Yeah, so much.
Well, and I'm gonna call you out as the international lipedema expert, because I think GLP-1s and lipedema can have a huge potential benefit, right?
Oh, I have never heard the word miracle associated with a medication before the GLP-1s, and primarily the tirzepatide, because that's what we use. But just like in 1 week, 5 people will say it's been a miracle for me. I mean, that's incredible. But I will say the body can figure ways around anything, and that it's not once you go on it and you feel like it's a miracle for you, you get on a new hedonic cycle and new things creep in. And so it's not a end all be all.
And I think the other thing is we don't want to get into this cycle where now we end up losing a lot of muscle mass as you're losing weight. Because if you rebound, given that your body has a set thermostat, right? So once you gain a certain amount of weight, your body will fight to keep it there. So as you lose weight, you're gonna lose some muscle mass in the sarcopenia. And the muscle's what really is metabolically active. So it's like turning down the thermostat a little bit. And so you've got to do the exercise. You've got to, whether you're taking glycine, creatine monohydrate, eating well, but you've got to maintain your muscle mass when you're on these medications.
Yeah, even in the microdoses, we encourage higher protein intake and weightlifting, big
Yeah.
for weightlifting for anyone with lipedema, obesity, lymphedema.
Which is just good, a good way to live, right? I mean, that's the way
It's
we
a
should
good way to live.
be living it to start with.
Yeah.
All right.
What
Next,
about
what do
amphetamines? Can I just ask you about that? Have you ever used
Oh.
amphetamines?
So I will tell you that's probably outside of my scope of practice, and I have
Okay.
not used them. I haven't read the data. Um, so, but
There's not
I
a lot
do.
of data. In fact, I have a lot of the data, which isn't much. I have got a couple papers on it, but if you go back into the history of amphetamines, they bind to lymphatic vessels and increase lymphatic pumping, and that's very clear. And
Oh,
so, and
interesting.
the reason we don't use it is because it's a controlled substance and people are afraid of it.
Yeah.
But I don't know if you remember, they used to sell it in the grocery store. Right, as
Oh,
you
yeah.
checked out Dexatrim, yeah. So it went from
Yes,
grocery
absolutely.
store to controlled substance. So
Yeah.
and I microdose it as well. And I've run it by cardiologists and they look at the small doses I use and they're like, I don't care. So it would be great if someone at the Mayo Clinic would take that and, and do maybe a research study on it or test it, because again, it's the only medication that we have available that improves lymphatic pumping. And instead of putting millions and millions of dollars into trying to develop an anti-lymphedema medication, we have one right now and it works terrifically because I've used it for 20 years.
Yeah, and if you could do the microdosing without any perceptible side effects, because the problem is just saying that now has taken on such stigma, right? That word.
It is, yes.
And that's part of the issue, is getting past the stigma and understanding the historical context because I had totally forgot that it used to be in the grocery lines for sure.
Yep.
Back probably in the 70s, early 80s before it was taken off.
Yep.
Yeah.
80s,
Oh,
I think.
that's fascinating. Yeah, no, that's
Yeah, like
I
5
think
milligrams, or some people are on 2.5 milligrams. A lot of them are on 10. And I usually go no high. If they get up to real, if they want to go to higher doses, I say, no, that's now you're in the realm of ADD, ADHD. You need to see a
Yeah.
psychiatrist. But
Yeah.
I stick really low and just have such great success. In fact, I have a woman who was over 300 pounds and I put her on 15 milligrams at a day, starting from 5 to 10 to 15, and she lost 75 pounds because she was so full of fluid.
Oh my goodness. Yeah, and that's the point. It's not she's losing fluid weight.
Well, and
Right,
then she
because
also,
now-
I mean, you lose fat too because
And fat too.
yeah, fluid makes fat grow, but yeah. And I
But
mean,
once
it
you
would
get-
clear up the fluid in that foot very nicely.
So do you find that these people, when you start them, they're diuresing a lot just because they're getting so much fluid? And
Absolutely.
right. So they're moving everything up the legs into the
Yes.
central lymphatics up to the left subclavian,
Yes.
which gets it into the central venous system, which now you're diuresing.
Right. It is a diuretic. It also is one of the best mast cell stabilizers that I know. And it improves lymphatic pumping and improves energy and cognition. I mean, there's the only downside is, very high doses, which you would never do as a physician. And
Yeah.
I've never had anybody become addicted to it or overuse it in any way in over 20
Yeah.
years of work with it.
And
It
there's
improves
so many-
fatty liver. I've got a
Yeah,
publication on that.
we could have an hour-long conversation just on
I
this.
know
This is
we
fascinating.
should move on in your cases, but
So
I
should
think it's a good.
do we need to put a qualifier in this conversation and say, I mean, is this off-label use? Is it general? I mean,
This research roundtable is for informational purposes.
Okay.
It's a conversation. It's not a CME event. It is to get information out there that'll help people take care of lymphedema, venous
Yeah.
disease, arterial disease.
yeah. Oh my gosh, that's been given pedal pulses are not palpable, next best study to obtain, and I think we talked a little bit about this. Always go to the least invasive, least expensive. And so that in this group would be a ankle-brachial index. The thing I see in medical records often is foot was warm, no further testing indicated. That the foot can be warm for a lot of reasons: inflammation, cellulitis. They just took their merino wool socks off. So don't let that be your guiding on it, that there's adequate perfusion. Get a validated test. Don't be subjective. And my 10 fingers have failed me more often than feeling pulses. That's why even if I am convinced I can feel a pulse, I still get an ABI, because what I've left in the medical record is a validated measure that I can compare year to year if I need to. And I think that helps out my colleagues too, because now they have a metric to look at and compare to. You can't control pulse exams are so finicky. I mean, you get people that say it's a 4 out of 4. I like using a 3-point scale. It's either absent, it's decreased, or it's bounding. Those are my 3 things. And so and then venous ultrasound, of course, I'm not talking about veins, so that doesn't help us. CT angiogram is going to expose to radiation. It's a relatively expensive test, and you're getting dye. And then going to the most invasive test would be an angiogram by ephemeral approach. That's going to be done by one of our either cardiologist or interventional radiologist or one of our vascular surgeons.
Nice.
Next slide, please. And that's just the documentation to show. So here's what a typical study looks like. We look at the waveforms, we look at the absolute pressures, and then we're fortunate in our lab that we get TCPO2s on everybody. That's not very common. If you see TCP2s that are really low, less than 40, so what we're looking at is when the patient's lying flat, so supine, if you elevate the leg for, I think it's 5 minutes, and the pressure and the TCPO2s go way down, that's suggestive of arterial disease. And then if you put the feet all the way down in a dependent position and the TCPO2s come up, that's suggestive again of arterial disease. But in somebody who's got significant edema, these numbers can be all thrown off. So you've got to put it in the context of the physical examination to be able to tell what's going on. Next. So we ended up getting a CT angiogram on this gentleman because we were suspicious of peripheral arterial disease. And we already talked kind of about this angiosomal deficit and recognition of lymphedema not healing. And on the CTA after the non-invasive arterial brachial index, he actually had proximal occlusion of his anterior tibial artery, and that is the angiosome that you're going to. So that lateral foot, top of the foot, he needs his anterior tibial and dorsalis pedis. He had a stenosis within the perineal artery and occluded posterior tibial. So this guy actually has, kind of a little bit of an issue because he's got 3 vessel disease in his left lower extremity. So we sent him on to vascular surgery, and there was no options for reconstruction. So this gentleman's a great candidate for an arterial pump. So instead of just going to an amputation, arterial pumps are very good for helping create angiogenesis over the time. We use it for an hour, 3 times a day. The one we use is the Artisys by ACI. That's the one that was used in a study here in 2008. There's well over 45 papers and peer-reviewed published literature about arterial pumps. There was a change in coding last January, so we're having great success now with getting these pumps covered for instances like this. And he would use it for an hour, 3 times a day. Usually we'll start to see improved angiogenesis within about 8 to 10 to 12 weeks. And compliance with utilization, I tell all patients, it's like going for a walk for an hour when you use your arterial pump. And they all seem to say, well, that's great because, I haven't been able to walk for an hour for years. So utilization, I think once we do the right education, is good. And the other nice thing about the arterial pumps, it helps reduce edema in the legs. We hear that consistently. In fact, to what we just talked about, Karen, people often have to turn off their pump and go to the bathroom, much like you see also with lymphedema pumps when they're using their arterial pumps. So they get a little bit of that diuresis effect also with using this device.
I could see that.
All right. Next, how are we doing on time here? It's 22.
We're doing
okay?
Great. Yep.
Okay. This gentleman, 80-year-old, this gentleman's still working as an attorney, diabetic, smokes cigars on a regular basis. There is really no allowable amount of smoking, right, with any lower extremity wound. So we get to have that fun chat with him, and I have done this talk so wrong so many times in my career. And now the first thing is telling them I'm not judgmental. I just really care about you. I care about your legs. Smoking's clearly associated with cancer, heart attack risk, cerebral vascular accident, strokes, and lower limb loss. And I think when we approach it from a non-judgmental, I think we're much more successful in helping people. I'm also taking the tack now with people that smoke a lot of cigarettes. I tell them, I want you to start rolling your own cigarettes. So don't buy a can, buy a pound, buy the cleanest tobacco you can, buy the paper that has a filter, and I want you to start rolling your own cigarettes. And almost everybody says it tastes better and they smoke less because it takes time to roll their own cigarettes. And we're using that to get to the point of now it's time to get off, right? But we have to, I'm trying to take away people's best friends, and it's really hard. So it's just another way to kind of get them off. So this gentleman, he had bilateral popliteal artery aneurysms. No, if you ever see popliteal artery aneurysms, make sure and look for aortic aneurysms. You'll see them about 40% of the time. He had no abdominal aortic aneurysm. He had previous percutaneous intervention with stenting, and he had developed really significant tibial, he had been shedding debris from his popliteals into his legs. And so he had significant tibial occlusive disease as well that was not reconstructive. On top of that, he had congestive heart failure. And I think he had some renal dysfunction as well. So really, you can see his right leg, and he's necrosed his right great, second, third toe. You can see those really significant pitting ulcers in his mid calf, and then you can see his left leg. Now, Karen, in most wound clinics, again, I would surmise that they look at all this and they miss the lymphatic component of these lower extremities. It's just, well, they might say it's swollen and there's edema, but I'm to the point in my career where I'm willing to put in the chart, this is lymphedema. He's got lymphatic dysfunction, and, we've got to start paying attention to the lymphatic dysfunction of these people, because by getting limb reduction, especially in peripheral arterial disease, that's going to help decrease our risk of lower extremity amputation. That's his biggest risk right now, is amputation. So again, that fuzzy whale, that edema wear is only 8 millimeters. So we can put that on somebody even with arterial disease, macro arterial disease. You could do MLD in a patient like this, right? And if you can do MLD, you can certainly use this stimulating lymphatic component. And then we were doing hypochlorous acid soak on his wounds. And then the other thing we haven't really talked about yet is we hit hard on the micronutrients. So I'm trying to figure out, how can we make your endothelial cells make nitric oxide? So B complex, B6, B12, folate, all that helps in terms of nitric oxide production. Vitamin C. We've actually had a couple people with vitamin C deficiency in our wound clinic recently. It's people are not eating well, and the vitamin D3. Caroline Fife talks about that all the time. And D3 helps endothelial cell function. It's not a bone issue; it's endothelial cell function. And then we use a lot of diosmin hesperidin, so micronized purified flavonoid fraction. I was part of a team that worked on mouse carotids in Boston at one of the best endothelial glycocalyx labs in the United States, at Enno Ebong's lab. And Ron Mitra was the PhD fellow. So he, using diosmin, showed it actually helps arterial function as well. This was a mouse carotid model. So it's been shown in, now, and that's a benchtop. We got to do the clinical work now, right, in humans, but certainly the data shows a great function for venous and for lymphatic. And then we got to go in an arterial pump. And if you go to the next, so look at the date, this is July 31st. And approximately 4 months later, he healed the toes on his foot. And that's from edema reduction. Now he's still got a ton of edema, but go one more forward. I think I've got it. So here is comparing right foot and right foot. So this is where paying attention. So when I first saw him, I'm thinking, okay, macro arterial disease, got to get the edema down. And this is what's gonna save this guy's leg, is paying more attention to the edema, get him on the arterial pump, get the angiogenesis going. But that's going to take time. We can get the edema reduced really quick. Even if you get some of the edema down, it does make a difference in 8 micron perfusion. We're not going to reestablish a palpable pulse, I'm just trying to get the 8 micron stuff opened up again and get the endothelial cells to function to make nitric oxide to improve, down to the lowest part. So he didn't even lose a toe out of this.
That's amazing.
So it's a lot of hard work. Our nurses work so hard. Our certified lymphedema therapists work so hard. This is truly a multidisciplinary approach to getting limb salvage in these folks. Next case. And so, and we're going to stop with this case. This is a young 80-ish-year-old gal out of the Twin Cities who had three prior. She had a bypass to her dorsalis pedis, and that bypass went down because it wasn't a good runoff. It was a good vein, really good surgeon. And then this vascular surgeon attempted two more times to open up the graft and just couldn't get it to stay open. So the recommendation was a leg amputation. And you can see toes 1, 2, 3, 4, 5 all have some disease. Obviously, the second toe is not quite as bad. Now, she does not have a heel ulcer. Look at her studies. She's got really significant peripheral arterial disease. So we put her in a arterial pump again, the Artisist. And then we did the micronutrients. We did the Vosh soaks, the hypochlorous. We did, I think in her, we used Plurigel as well to help with the surfactant Paloxamer 188 effect. Go ahead to the next one. So arterial pump, an hour a day, fuzzy whale. So again, 8 millimeters stimulatory compression, the micronutrients that we just talked about, the biofilm mitigation. And I really got to give credit to Dr. Wolcott, who's down in Lubbock, Texas. So he wrote a paper in 2008 that looked at biofilm mitigation for limb salvage. And it's just now starting to really take hold and help. But he proved this back in 2008. If you really pay attention to biofilm, you can get limb salvage. And I think that's because we're decreasing inflammation.
Mm-hmm.
Decreased inflammation makes lymphatics work better. And then you get that microvascular arterial perfusion again. Okay, next slide. So, and there's her foot then at 6 months. So she went from multiple necrotic toes in the soft tissue. Now, this was not osteomyelitis, right? It's not like it was in the bone, and that's the differentiator. You're not gonna, if there's significant osteomyelitis, you're not gonna resolve that. That oftentimes is gonna end up with a toe amputation. So we have many patients, same foot, but mummified toes. We're doing the same thing for those folks, but we're trying to get them to the point where maybe 4 to 6 months later, they can do an amputation of the toe and heal that primarily. But she had a wonderful outcome in terms of full resolution, and she's now back at work at the she was working social care coordination or something in the Twin Cities, and she's back to work as an 80-ish-year-old woman doing wonderful. The interesting thing on the arterial pumper, she had pretty significant rest pain when we started.
Mm-hmm.
She couldn't tolerate the pump on the right foot. So what we did was right calf, left foot. And within 2 months, she could tolerate the pump on the right foot, and her night pain went away. She started sleeping better. And so with the arterial pumps, kind of like with lymphedema pumps, you're trying to apply as much square footage as possible. So if you treat the left leg, you're going to improve systemic nitric oxide oxygen production. You'll actually help that right foot, even though you're not doing the compression on to start. So treat as much surface area as possible to improve the outcomes. And so many of these patients, they won't tolerate initially the pump on the foot.
Mm-hmm. Makes sense.
So I think with that, Karen, given how are we doing time wise?
We have about 10 minutes.
10 minutes. Okay, good chance to wrap it up. And
yes,
there were so
we
many
have a
good
question
questions
for you. Yeah. We've answered a few, but the first question that came in, I thought I would wait on it, is, are you aware of any natural ways to heal wounds? Someone had a bout of cellulitis about 2 years ago, and she or he was a patient in a wound center. Do you have any natural ways to do it? I think a pump is pretty natural.
Pump is pretty natural. So I'm going to tell a brief story that we actually wrote this blog up for Caroline Feist's blog about a year ago. In the journal Nature, there was a baboon named Ruska. and they've over in Malaysia, and they've watched this troop of baboons orangutans for years, so they know them very well. Well, one night, two males got in a tiff, and the next morning they were taking pictures again. The next morning, and this one orangutan had a huge cut underneath the left eye. And what they observed over the next couple of days was the orangutan was grabbing very specific leaves from a tree, taking the leaves, chewing it, masticating it, spitting it back into the hand, and wiping it on the face. 6 weeks later, scarless healing of that cut underneath the left eye. And so it's the first time ever a non-human has been demonstrated to do purposeful wound healing.
Wow.
So I said, it's like, what tree was that? So I go and look it up. Well, sure enough, I forget the name of the tree, but it's the source of berberine. Have you ever used berberine for anything?
Oh, yeah.
It was berberine, and berberine actually is a natural stimulus for GLP-1 in your body.
It is.
Well, and guess what else it restores in the endothelium, Karen?
Glycocalyx.
The glycocalyx. So it's decreasing inflammation, decreasing hyperpermeability, increasing angiogenesis. And if you're going to get scarless healing, you have to have good lymphatic function, because lymphatics are soft tissue regeneration. So if you look at natural substances that are out there, hypochlorous acid, your body's macrophages make hypochlorous acid. So I would say that Vash, Pure and Clean, good hypochlorous acids are actually very natural, teleological, normal ways to help in healing. Different than hydrogen peroxide, different than betadine, different than Hibiclens. All those things tend to slow down healing. They're good to use. They're good to use if you're trying to mummify and keep something dry. But if you're trying to stimulate to heal, those substances tend to not help. I tell people, if you're going to use hydrogen peroxide, use it on the DNA stains in your carpet. So, but don't use it for wound healing. It's all wives' tales. The other big wives' tale is wet to dry. Wet to dry, saline doesn't work. All you're doing is making beef jerky out of the tissues. You're just drying it out. Gosh, Karen, can you think of any other? I'm just trying to think more.
So I have a great question for you, but somebody earlier asked about, you mentioned a whole bunch of companies and their products for getting into the wounds. Can you give that to Brenda so she could post that with your video or somehow send it to the participants? Sure. And here's a great question. So somebody mentioned that they had osteomyelitis after wisdom tooth extraction. Would hyperbaric oxygen chambers help with wound healing and these situations you showed and also with the jaw?
So I'm a member of the Underwater Hyperbaric Medical Society as well as the Aerospace Medical Association. They meet now conjointly, and so I personally don't perform hyperbaric. I took a week-long course in it, which gets me a little piece of paper and makes me dangerous. So I can't prescribe hyperbaric, but I know to recognize here's the indications where people can benefit from hyperbaric. And so osteomyelitis is certainly a benefit. There's some really interesting ones like central retinal occlusion, acute hearing loss can benefit. A failed flap. So if you've done a transmetatarsal amputation and closed and it's failing, if you've done a free flap, those are oftentimes good indications. So there are some very good indications, but the vast majority of wounds we see will not be approved for hyperbaric because there's not the data. There's not the validated data. And hyperbaric's expensive. You're talking $2,000 per session, 5 to 6 weeks, but it is so valuable for so many people. And again, we're very fortunate here to have a phenomenal hyperbaric team to work with. So I would say of about half the consults I send through, there's other ways to get them healed, but I'd rather over ask than under ask on a lot of the complex patients we're working with. So the other thing I would tell you is be careful. Not all oxygen in a tent is hyperbaric. And there's plenty of pop-up shops where they have basically an inflatable and they're blowing oxygen into it. That is not regulated hyperbaric. And any place you get hyperbaric, you want to make sure they're certified by the UHMS, the Underwater Hyperbaric Medical Society, because it's safety. I mean, somebody just died within the past 6 months, I think, from an explosion in a uncertified facility.
Yeah.
And you certainly, fire risk is incredible. You're talking about pressures that are incredibly high. I mean, it's like going down 33 to not quite 66 feet, but 1 to 1.5 atmospheric pressures. So hyperbaric in the right conditions is incredibly safe. In the wrong conditions is incredibly dangerous.
See if there's any more.
Well, you know that this is my 5-minute warning. I always reappear 5 minutes before we are out of time. The comments have been amazing. The questions from the audience, so good in this
Really
conversation. I'm going to hold you to this, Dr. Melin. You did say we could do another whole hour. Not tonight, but we will have you back.
Mm-hmm.
Oh my gosh. Any time to spend time with you guys? For sure.
That's lovely. We did have one question that was just a little bit confused about the lymphedema pumps and the arterial pumps. Both are available through Lympha Press, though. So please do go to lymphapress.com if you'd like more information or an in-service on any of those items. And with the 4 minutes now, how would you like to close it out, Dr. Herbst? Any final thoughts?
Do we need to differentiate on lymphedema pumps and arterial pumps?
Could you just do a quickie, please?
Yeah, and I'm going to make a funny comment. I do a lot of appeals on patients to help them get the pumps they need. I was appealing to an insurance company to get them an arterial pump. And this particular physician says, well, we can't approve that, but I can approve a lymphedema pump if that would help. And I just thought it's two different pathophysiologies. You can't replace an arterial pump with a lymphedema pump. And I think it highlights, again, the lack of education about lymphedema in the United States and lymphatic physiology and how critical it is to health. So lymphedema pumps are meant to basically activate your siphoning system to pull fluid out of the legs to get it into the central lymphatic system to get to the thoracic duct to go into the subclavian. It's not going to end up pushing fluid into the veins. That's not how it works. So you're really just trying to get the natural system to work the way it's supposed to work. And arterial, so they're much lower pressure, different waveforms on the skin. It's supposed to be like the certified lymphedema therapist who are attending the night session. It is automated certified lymphedema therapist. It does not replace a certified lymphedema therapist. Ideally, if you're using a pump, you have a good connection with a certified lymphedema therapist. And then the arterial pumps, much higher pressure. You're trying to create significant shear to get angiogenesis. And you'll get the byproduct of less swelling, but it's a totally different pressure, different waveform, different intent. And they're all different than a venous pump as well. So you have to understand what the diagnosis is so you can identify. And the lymphedema pumps, I just saw something come across about sequential compression. There's also that concept of receptive decompression. You're trying to clear out, especially with the O2s, the kind of the blockages up in the belly, the groins, clear that pathway and then start coming up. So significant difference between lymphedema pumps and arterial pumps.
Mm-hmm. And quickly, can you just tell us about honey? Can you use honey for healing wounds?
Honey's been around since the time of the pharaohs. There's Therahoney, Metahoney. I think you may have all seen there was a recall recently on some of the available honeys. So a good medical grade honey, look at like places like Medical Monk, One by Prism, Medline are some good sites to buy good, reputable. Medi, who makes compression stockings, also has a really good called Activon. That's a really good therapeutic honey. So yeah, we use a lot of honey in conjunction with doing wash soaks of wounds.
And we are at the wire here. Eric Ansart, so lovely to have you with us for this conversation. Did you have any closing thoughts?
I just wanted to thank Mark for being here today. Karen, it's always wonderful. I tell Brenda, I feel like my IQ goes up a couple of points just sitting in some of these meetings. But seriously, I just had really enjoyed listening to the two of you speak. And Mark, I have to tell you, you're the first person, this was years ago now, who really helped me to understand that there is a lymphatic component to even diabetic wounds and vascular wounds and ischemic wounds. Lymphedema impacts our entire body, so it can kind of show its face in many different ways. So hearing that from you and hearing today's presentation, really appreciate you.
Hey, thank
And-
you, Eric.
And I will,
you know,
I will say, oh, go ahead.
Oh, I was going to say, I just wanted to highlight Karen because Karen's speaking at the Mayo Lymphatic Disorder Symposium, May 13th through the 15th in Rochester. So if y'all are interested, make sure and look up Mayo Clinic lymphatic course. We're giving, I think, 18 and a half or 19 CMEs, and we got a really good bunch of people that are going to talk about everything from diagnostics to therapeutics to the surgical part. So and a lot of good CLT. And we've kept the prices down. Hotel prices in Rochester are very, very reasonable. So come and join us in May if you're interested, please.
And I have to say, it's just such a rare person who can go from micro level to macro level and even touch on politics and make jokes all in 1 hour. So it's been a pleasure. And I do hope we can have you on again soon.
Oh my gosh, it'd be a privilege. I look forward to it. Thank you.
Yeah, the
Awesome.
privilege was all ours. Thank you, everybody, for logging on to the live. Thank you to our wonderful guests. I think Robert Schneier from our audience said it so well. I learned more in this hour than I have learned in the past year. Well, that's why we do it at the Research Roundtable. You never know what you're going to learn, but you will always learn something. And Lympha Press is so honored to provide this information to you, clinicians and patients. You can count on us every month. We'll see you again soon. Have a great rest of the month, everyone. Thank you again. See you.